Hello, ladies and gentlemen. Today I'm going to take you through a presentation known as Patient Blood Management, PBM. And inside that we have what we call Transfusion Practitioner, TP, and also Hospital Transfusion Committees, HTC, Stephen Jolomori. Now, what is this PBM, or Patient Blood Management? These are just guidelines. These are just guidelines to inform decision making. So these guidelines were given name as patient blood donor management. So in Malawi, we can equate it to our guidelines called clinical use of blood and blood products, which was issued by the Malawi government through the Malawi Blood Transfusion Service. But blood management is a little bit different from the clinical guidelines in a way that the focus in the PBM is on the patient. It's more like the patient side. It's more on the patient side, a lot of scrutiny on the patient side to sort of to scrutinize blood requests, to scrutinize when the blood is necessary to be transfused. So this is patient blood management, which is an evidence-based multidisciplinary approach to caring for patients who might need blood transfusion. PBM encompasses all processes of transfusion decision-making process. This is the first point whereby a clinician makes a decision that this patient should be transfused. So decisions like at what hemoglobin level should we transfuse? Is it at 6? Is it at 5? Is it at 8? And this particular patient, at what hemoglobin level should we transfuse? So it starts from that initial patient evaluation and continues through clinical management. So clinical management means the request has gone to the laboratory, the lab has issued the unit after grouping and cross-matching, comes back to the ward, and the ward hangs the unit, transfuses the patient. The personnel in the ward monitors the patient for any transfusion reactions. After the unit has been transfused, records that the unit has been transfused, the blood group of the unit, and the number of units, and also the diagnosis that triggered the blood transfusion. So there are also other techniques embedded in this PBM to sort of minimize blood transfusion. For example, you have a patient with, for example, a hernia, a surgical condition hernia, and the hemoglobin is 6. And you check, this is iron deficiency anemia. But the surgeons will say, no, I cannot operate with hemoglobin of 6. All right. Now, do we need to transfuse this patient? What do we do? So PBM advocates for you give hematinics to this patient, medicines to boost the blood level. He goes, hernia is not an urgent thing. If it's not strangulated, he goes, takes the hematinics maybe for 2-3 months. He comes back, the HB is corrected. Maybe HB comes back to be 10 or 11, and that is fine. So you see the blood level has been corrected without any transfusion. So these are the the principles of PBM. So like I said, it's almost the same as our clinical use of blood and blood products, but only that this is more of sort of scrutinizing further and is coming from the other side, the world side. These techniques are designed to ensure optimal patient outcomes while maintaining the blood supply to guarantee that blood components are available for patients when they are needed. Now, the example I gave about this hernia, this is not an emergency. So you can give him a tonics and life goes on. Now we have postpartum hemorrhage. Those patients who not tolerate the hematinics. They need blood there and then. Now, these are the patients who need blood. So you can see that we have saved blood from these elective surgical procedures, and we give them to the patients who really need the blood, who cannot sort of wait for hematinics to work for them to sort of to boost their blood level. So young patients, pediatric patients with severe malaria, they may need some blood transfusion just to push their HB up. And then maybe later you can supplement with hematinics, but at least the first thing should be transfusing. So there are big organizations which are in forefront advocating for this, and this has been there for years. And these are AABB, and this was formerly known as American Association for Blood Banks, but now it was sort of rebranded to mean Association for the Advancement of Blood and Biotherapies. And also International Society of Blood Transfusion, ISBT. These two are global leaders in PBM and provide educational resources. They provide also financial resources. And these resources help hospitals build evidence-based PBM programs that personalize blood transfusion to improve patient outcomes. Now, this is a new concept in developing countries, especially Malawi. It's new, but roughly we are doing this in the background because all this, somehow this prioritization is being done, but we just want now to sort of to bring out this these processes and unearth the name that, okay, let's practice PBM. So it's like, let's practice evidence-based medicine. All right. So we want to push this PBM agenda so that blood should go to those who really need them. PBM puts patients at the heart of decision about blood transfusion to ensure they receive the best treatment, and inappropriate use of blood and blood components is avoided. PBM requires a disciplinary approach, and TP plays a vital role. Now, who is a TP? TP is a transfusion practitioner. And who are these transfusion practitioners? Let's go to the next slide. So the term transfusion practitioner is a job title in other developed countries. So in the US, in the UK, these TPs are there. And in fact, it's a job title. But the word should not sort of confuse us, because these people are not new. These are already trained hospital personnel, healthy personnel. So like in example, in Malawi, you can have medical assistants, nurses, lab scientists trained to be transfusion practitioners, medical officers, consultants trained as transfusion practitioners, physiotherapists, epidemiologists, as far as they understand the concepts in the healthy setting. If we say malaria, they understand what malaria is. When we say blood transfusion, they understand what blood transfusion is. These can get this short course training and become transfusion practitioners. And this has been there for almost 20 years worldwide. But much publication started cropping up in 2011, and ever since the roles of transfusion practitioners have been highlighted. And in Malawi, at the MBDS, there was a joint program with the NHS BT UK, piloted a TP program. 2 TPs were trained and implemented the activities in their respective hospitals. So there was one at Mulanje Mission Hospital, and the other one was Zumba Central Hospital. So they did quite a good job only during the pilot, but their work is not traced currently. So they might be doing very well, or they may not be doing very well. So this is what we're sort of now trying to rejuvenate, bring it forward, because if we remember, MBDS has been training healthy personnel in blood safety. And it's just a matter of calling these transfusion practitioners. And now we have come up with this training now to sort of specifically to sink in these PBM transfusion practitioner issues. And then these TPEs, they have been called different names. In other places, they call them transfusion nurses, transfusion trainer, transfusion safety officer, transfusion quality officer, transfusion clinical nurse, hemovigilance officer, or PBM coordinator. Like I said, we do not have this established post in Malawi. And do we need to fight for this established post? Yes or no? But no, because the people we are using, they're the same people in the hospital. So it's a matter of just appointing somebody, just like what we do with other coordinators. We have ART coordinators. We have TB coordinators. So it's just a matter of appointing one, training him, and he goes back and we implement PBM and act as a transfusion practitioner. So in essence, all those who underwent the blood safety trainings by the MBDS some few years ago, those can be called transfusion practitioners. The only difference is maybe during those trainings, we do not emphasize these issues of PBM, issues of transfusion practitioners, but they can also be called transfusion practitioners. Role of TP, their roles. So TP is an individual. So we have head of hospital transfusion committees. So their roles, they're almost the same as hospital transfusion committees, only that this time around, a TP is an individual, while hospital transfusion committee is a committee. So the primary role for the TP is to promote safe and appropriate use of blood to clinical colleagues within and outside of the laboratory wards. So outside laboratory, we mean wards. TPs play an important role in developing a PBM culture within healthy care establishment. They work with the PBM team, engaging scientific, laboratory, and clinical colleagues to understand the importance of PBM, and are often involved in implementing the strategies to support it. Some countries have implemented this, and data from one of the Australian hemovigilance programs also supports the key role that the TP plays in the management of hemovigilance in the healthcare setting, including investigating, reporting, and provision of education. For your information, in Malawi, annually we're supposed to provide data to the World Health Organization on blood safety. There's a part which involves data from the hospital side. It has been very difficult to extract this data. And it is only if the hospital transfusion committees are very active in advocating for good quality data recording, TPs are very active in promoting data collection, then at least we have this data which has been lacking for years to be submitted to World Health Organization. And also for hemovigilance purposes, we want to understand what happens if somebody gets blood. There are some who may die because of the disease, maybe it was in an advanced stage, but some may die just because of the transfusion. A blood unit can kill a patient. A component can kill a patient. So this is why we want these TPs to be very active, hospital transfusion committees to be very active, PBM culture to be implemented in the hospital settings. Hospital transfusion committees, we are all aware about this, advocated by World Health Organization. And in Malawi, the first one was established in 2004 at Queen Elizabeth Central Hospital. And one of the successes of this hospital transfusion committee at Queen's was the drafting of the guidelines in clinical use of blood and blood products. And these are the guidelines we are currently using. We have also recorded success stories from district hospitals, like Baraka District Hospital. We recorded success stories from there, and we can read in papers. If the International Society of Blood Transfusion newsletter featured an article on hospital transfusion committees in Malawi, and the Baraka was highlighted in that. You may access this online on the internet. It's there. You can learn more things from there. And what are the roles of the hospital transfusion committees? These are well-known roles: to monitor safety, adequacy, reliability of supply of blood products, IV replacement fluids, and drugs essential for transfusion practice. To monitor the usage of blood and blood products, to establish, monitor, regularly review systems and procedures for effective clinical transfusion practice, including those for ordering, collection, and administration of blood and blood products. Now, if you think around this third point, and if you remember what I mentioned about the PBM, it's the same. So this PBM is there, but it's in the background. So I just want to highlight it. Just want to sort of, if you grab an international journal on blood use, blood safety, and you come across PBM, the word should be familiar. It shouldn't be like the first time you're seeing it. To promote the training of clinical, laboratory, and support staff involved in the transfusion process, to review all incidents of severe adverse reaction or errors associated with transfusion and identify any corrective action required, to promote the safety of healthy personnel working with blood, work hand in hand with Malawi Blood Transfusion Service in motivating, mobilizing, recruiting, and retaining regular blood donors. As you know, the national blood policy doesn't allow hospitals to collect blood on their own, the policy. So what they are encouraged is they should work hand in hand with the MBTS to mobilize the blood donors. So if they mobilize the blood donors, you call MBTS, they will come, you go collect with them, and then you agree on the share of blood and blood products. Should you need more supplies than usual. Membership of HTCs, and this is already known, but we can repeat. Multidisciplinary again. So the multidisciplinary in HTCs is about membership, while in the PBM it's about also membership, but the processes and also who to get involved. So those departments who have decision in blood-related issues, like blood cannot be at the hospital without involvement of administration. So we need administrators there in the committee, on top of the clinical nursing department, laboratories department, wards, and transfusion practitioner. And we encourage that all these hospital transfusion committee members, they should be TPs, they should be transfusion practitioners. And being transfusion practitioners, it's not that you're supposed to go and get a degree or master's or PhD in HTCs. No. You just need to have the baseline qualification: nurse, clinical officer, medical officer, statistician, as far as you understand the concepts in the hospital setting. And then you get trained. Then you can go back and implement this and practice as transfusion practitioner. PBM, HTCs play a key role in blood conservation, with TPs play an important role. So this TP can be embedded within the committee. TP can be the chair of the committee, but what we do not encourage is TPs to work in parallel with hospital transfusion committee. So let's say you have a hospital transfusion committee with the chairperson and all the executive committee, and you are trained, you go back and say, hey, I'm the only trained TP in, as far as Malawi is concerned, I was in the pilot group, so let me take over this. You guys stop. I know what to do. I think people are not going to like you if you take that approach. So you need to be embedded, you need to be within the hospital transfusion committee. Where there are no TPs, you can work on your own, just like how other coordinators work. We have ART coordinators who do not have any ART committee or TB committee, but you find those coordinators working efficiently. TPs can work on their own. Where there's no HTC or ineffective hospital transfusion committee, TP may assume roles of HTCs upon approval by the hospital management. Okay. You talk to the director, you see, we have tried the hospital transfusion committee. Would you please try me? I want to work on this on my own. And then the hospital director or the chief medical officer may say, okay, go ahead and let's see. That can be tried. And the title may be changed to be in line with other local titles. So like transfusion coordinator, transfusion in charge, but we prefer to maintain the TP word, because you, at some point, you may go to another forum, international forum, and you say, I'm a transfusion coordinator. People will not understand you, what you're talking about. So it's better we maintain the TP and make it more exciting. And Malawi context, what do we have? We have HTCs with sustainability challenges. Of course, we have successes from there. PBM, not clearly highlighted, but again, is present in the background, but we just need to push it forward. We need to talk about PBM. No TPs, although they are there, they've been trained by the MBDS. They're there, and they can assume TP roles. So this training is a little bit unique from the previous one, because now in this one we selling the whole agenda of PBM, TP, HTC included. So those who have undergone this training and who complete the training, at least they'll have better understanding of all the issues in the PBM, because we're going to also do sort of a detailed data collection in the world, detailed transfusion side effects, how to capture them. Our next steps after this course, what do we do? You get a certificate of participation, and if you decide to take a small test, it will be a simple one. You get a certificate saying that you have successfully completed the course. I encourage people to get the successfully completed course certificate, because you never know what happens in future. You may show that elsewhere. And I want to challenge people to voluntarily have their own plans to implement whatever they have learned in their respective hospitals. We have captured quite a few hospitals, so there are quite a few of you. So take advantage of it, and let's see how it will go. So this is the end of this presentation. Should you have any questions, please feel free to ask during our discussion sessions. Thank you for your attention.